Hello everybody. Today we are going to discuss about trauma-induced coagulopathy. In severe trauma patient, coagulopathy is frequently observed in the acute phase of trauma with profound effect on the outcome. This coagulopathy is caused by the multiple factors associated with the trauma itself, as well as certain intervention and has been described with various terms. So we refer to coagulopathy caused by diverse trauma-associated factor as a trauma-associated coagulopathy, and coagulopathy caused by trauma itself as trauma-induced coagulopathy. So inconsistency in acute coagulopathy of trauma shock theory. Coagulation suppressed by the activated protein C. In acute coagulopathy of trauma shock theory, the trauma shock stimulates the release of the soluble thrombomodulin from endothelial cells. This soluble thrombomodulin binds to the thrombin to form thrombin thrombomodulin complex, which activates protein C, which in turn suppress the prothrombinase complex from factor 5 to factor 10, a complex activity and thrombin formation. However, thrombomodulin is the receptor of thrombin and protein C on the endothelial surface and regulates the coagulation and complement system. Hyperfibrinolysis by degradation of plasminogen activator inhibitor. In in this theory, the activated protein C decomposes the plasminogen activator inhibitor. So, because the plasminogen activator inhibitor suppress the fibrinolysis, this plasminogen activator inhibitor degradation accelerate the fibrinolysis. However, activated protein C does not increase because, as mentioned above, total thrombomodulin activity in the vessel is impaired. Furthermore, plasma plasminogen activator inhibitor level does not increase immediately following trauma. Chapman et al. Indicated that total plasma plasminogen activator inhibitor in severe trauma patients with hyperfibrinolysis did not increase compared to that in healthy control. Therefore, plasminogen activator inhibitor degradation does not appear to play a significant role in the pathogenesis of hyperfibrinolysis in acute phase of trauma. About DIC phenotype, we have repeatedly advocated that trauma-induced coagulopathy is DIC with fibrinolytic phenotype. However, it has been demonstrated that coagulation activation is also underlying DIC. We consider that this argument might have resulted from misunderstanding the phenotype. DIC divided into two phenotypes, that is fibrinolytic and thrombotic phenotype. In critical care settings, sepsis-induced DIC is frequently observed, which is representative of thrombotic phenotype and characterized by suppressed fibrinolysis and microvascular thrombosis and ischemic organ dysfunction. Trauma-induced coagulopathy is considered type of DIC with fibrinolytic phenotype, and it is markedly different from the DIC with thrombotic phenotype. So, coagulation activation is observed in both phenotype of DIC. Plasminogen activator inhibitor suppress fibrinolysis in DIC with thrombotic phenotype, where fibrinolysis is activated by tissue plasminogen activator in DIC with fibrinolytic phenotype. Therefore, although sepsis-induced DIC does not lead to massive bleeding, trauma-induced DIC in acute phase of trauma contribute to massive bleeding and death. So, characteristic of the DIC phenotype. So, there are two types of the phenotype, that is fibrinolytic phenotype and thrombotic phenotype. Fibrinolytic phenotype seen in acute phase of trauma, thrombotic phenotype seen in sepsis. Coagulation is activated in fibrinolytic phenotype and also it is activated in sepsis type phenotype. Fibrinolysis is activated in fibrinolytic phenotype, it is suppressed in thrombotic phenotype. Plasminogen activator inhibitor is low in fibrinolytic phenotype, high in thrombotic phenotype. Clinical symptoms, it's bleeding in fibrinolytic phenotype, organ dysfunction in thrombotic phenotype. Now, trauma-induced coagulopathy, DIC with the fibrinolytic phenotype, it consists of coagulation activation, hyperfibrinolysis, and consumptive coagulopathy, which leads into acidosis, hypothermia, and dilution. Pathophysiology of trauma-induced coagulopathy, that is coagulation activation, that is release of procoagulant in systemic circulation, impairment of endogenous anticoagulant activity, and thrombin generation in systemic circulation. Then hyperfibrinolysis, acute release of tissue plasminogen induced hyperfibrinolysis Coagulation activation induce hyperfibrinolysis and consumptive coagulation. Then coagulation activation, procoagulant in the systemic circulation. In severe trauma patient, particularly those with the blunt trauma, massive tissue injury accelerates the thrombin generation. Previous study shows that spontaneous thrombin generation in severe trauma by using non-stimulation thrombin generation assay. Shortly after trauma, various procoagulants are observed in systemic circulation, which results in this spontaneous thrombin generation. Platelet-derived microparticle is a well-known procoagulant in acute phase of trauma, and several studies have indicated that various other cells derived from microparticle are subsequently released into systemic circulation in acute phase of trauma, such as leukocyte-derived, erythrocyte-derived, and endothelial-derived microparticles. Tissue factor is exposed on the membrane of certain microparticles. Therefore, elevation of the tissue factor antigen level in plasma is reported in previous study may reflect increase of tissue factor exposing microparticles. Recently, the brain-derived microparticles were detected in the brain trauma animal model. These brain-derived microparticles expressed neuronal and glial cell marker, procoagulant, phosphatidylserine, and tissue factor. In addition, other injury organ may possibly release microparticle in severe trauma. Extracellular DNA and DNA binding protein, which are well known as damage associated molecular pattern or procoagulant observed in systemic circulation shortly after trauma. Histone and histone complex DNA fragment were detected in the systemic circulation shortly after trauma and induce inflammation, coagulation activation, and organ dysfunction. Furthermore, early release of high mobility group box nuclear protein mitochondrial DNA was observed in severe trauma and induced inflammation and coagulation activation. In penetrating trauma, especially stab wound, there is less tissue injury than in the blunt trauma. Therefore, procoagulant production and the coagulation activation are far less than that immediately following blunt trauma. Procoagulants circulating in systemic circulation, microparticles are platelet-derived microparticle, endothelial-derived microparticle, leukocyte-derived microparticle, erythrocyte-derived microparticle, and brain-derived microparticle. Then extracellular DNA and DNA binding protein, HMGB1, mitochondrial DNA, and histone complex DNA fragment. Now, impairment of endogenous anticoagulant activity. In healthy subjects, the coagulation activation is regulated by endogenous anticoagulant such as antithrombin and thrombomodulin protein C pathway. However, in severe trauma, endogenous anticoagulant activity is immediately impaired and dysregulation of coagulation activation is observed. Many studies reported an early decrease in antithrombin activity in severe trauma, and thrombin generation assay shows negative correlation between antithrombin activity and generated thrombin, regardless of decrease in prothrombin concentration. These results indicate that decreased antithrombin activity causes dysregulation of thrombin generation. Most of the thrombomodulin in the body is found on the vascular endothelial cell. Therefore, evaluation of anticoagulation ability of thrombomodulin is difficult. However, in severe trauma, endothelial damage leads to the release of thrombomodulin on the vascular endothelial cell as a soluble thrombomodulin in the systemic circulation. Furthermore, plasma concentration of protein C decreases shortly after severe trauma. Therefore, anticoagulation ability of thrombomodulin protein C pathway is impaired with resultant dysregulation of thrombin generation. Although some investigators have advocated that activated protein C increases and suppress coagulation, the increase in activated protein C did not reach sufficient concentration to inhibit thrombin generation. Thrombin generation in the systemic circulation. The presence of procoagulant in the systemic circulation, together with the impairment of endogenous anticoagulant activity, induces coagulation activation and thrombin generation. The half-life of thrombin is very short, which precludes the measurement of plasma concentration. Therefore, other parameters have been used as evidence of thrombin generation in the systemic circulation. So soluble fibrin and fibrinopeptidase A are considered to reflect active thrombin because these markers are formed as a result of direct action of thrombin on fibrinogen, which is followed by fibrin formation. Early elevation of plasma concentration of this marker are evidence of thrombin generation in systemic circulation and have been repeatedly reported. About hyperfibrinolysis, in severe trauma, hyperfibrinolysis, which is combination of fibrinolysis and fibrinogenolysis, is frequently observed. This hyperfibrinolysis is caused by acute release of tissue plasminogen activator and coagulation activation. Now, shock-induced hyperfibrinolysis. One of the key enzymes in the fibrinolysis is tissue plasminogen activator. Tissue plasminogen activator catalyzes the cleavage of plasminogen to plasmin and thus initiate fibrin and fibrinogen degradation in the plasma. The main source of plasma tissue plasminogen activator is Weber palette body in systemic vascular endothelial cell. Severe shock stimulates endothelial cell and induces the release of tissue plasminogen activator from the Weber palette body into systemic circulation. This is called as acute release of tissue plasminogen activator. Furthermore, acute and massive tissue plasminogen activator release induces the hyperfibrinolysis. Thromboelastometry such as ROTEM can detect acute release of tissue plasminogen activator as a lysis of clot formed in the test tubes. Now about coagulation activation induced fibrinolysis. In severe trauma, hyperfibrinolysis is frequently observed regardless of presence of shock. In particular, severe isolated head trauma, which is not usually complicated by hypotension, is typical case in which hyperfibrinolysis may occur without shock. Hyperfibrinolysis without shock is induced by coagulation activation and is recognized by elevation of D dimer and fibrinogen degradation product level. Kushimoto et al. Reported correlation increase in fibrinogen degradation product and plasmin alpha 2 plasmin inhibitor complex level. Furthermore, fibrinogen level markedly decreased as a result of hyperfibrinolysis. Many other studies reported that D dimer and FDP level increase not only in isolated head trauma but also in torso trauma, regardless of presence of shock. In acute phase of trauma, plasminogen activator inhibitor activity has not yet increased enough. Therefore, although trauma-induced coagulation activation reactively causes fibrinolysis is not suppressed by plasminogen activator inhibitor. Non-suppressed fibrinolysis consumes alpha-plasmin inhibitor and consumption of alpha-2 plasmin inhibitor accelerates dysregulation of fibrinolysis. Now about consumption coagulopathy. As mentioned above, in severe trauma, coagulation activation and hyperfibrinolysis are simultaneously observed. Therefore, various coagulation factor and platelet are consumed in acute phase of trauma. Consumption of coagulation factor has been repeatedly reported because this phenomenon is easy to evaluate by presence of coagulation factor. The plasma fibrinogen level decreases more frequently and earlier than the level of other routinely measured coagulation parameters. Furthermore, infusion and transfusion leads to more readily dilution of fibrinogen than other coagulation factor. The other coagulation factor cannot compensate for role of fibrinogen as a unique precursor of fibrin. Therefore, decreased fibrinogen may lead to massive bleeding and poor outcome. Other coagulation factor activity also decreases correlatively with severity of trauma. Of this, factor 5 activity decreases more than the other factor activity. Together with the decreased fibrinogen level and decreased factor 5 level were detected in patient at the accident site. However, platelet count are seldom reduced in critical level. Thank you guys.